Hello, everybody, and welcome to today's webinar on eating disorders here with us at CalMap today. Let's go ahead and pull up the slides, and we're going to review just a few quick announcements before we get into today's presentation. So next slide, please. A couple of quick announcements. I think most of you know we are CalMap, same as the old CAP, and we are primarily a warm consultation lab. So if you have specific questions about patients and your patient care, please do call us during business hours. Our phone number is right there. In addition to talking to psychiatrists, you can also talk with psychologists, including our own Dr. Bruett, who will be speaking today for very specialized guidance on particular topics like substance abuse or eating disorders or autism. And just so you know, we have these recordings online at our YouTube channel, as well as on UCSF's CME portal for viewing online and for answering questions in order to get CME credit. Next slide, please. Here's a quick word on our disclosures and on our funders. There are no relevant financial disclosures for today. And with that, I'd like to introduce our speakers for today. We are very fortunate to have with us Dr. Lindsey Bruett, who is a licensed clinical psychologist and associate clinical professor at UCSF. She consults with families and providers of children and adolescents. Dr. Bruett's areas of expertise include evidence-based treatment and assessment of eating disorders, anxiety, depression, disruptive behavior, trauma, and obsessive compulsive disorder. She highly values the importance of including family when supporting young people and specializes in parent-based interventions. Dr. Bruett has extensive experience providing care and consultation across the socioeconomic spectrum and is committed to continually striving to reduce healthcare disparities caused by systemic oppression. She leads the Eating Disorders Program at San Francisco General Hospital. Dr. Amanda Downey is a pediatrician and psychiatrist who cares for adolescents and young adults with eating disorders. She works with patients and their families to develop a treatment plan that honors their unique strengths and challenges. Through education, advocacy, and research, she strives to dismantle the systems that increase risk for eating disorders and improve eating disorder treatments, specifically novel pharmacotherapies for anorexia nervosa, such as psilocybin. She is the Assistant Medical Director of the UCSF Eating Disorders Program and the Medical Lead of the UCSF Translational Psychedelic Research Program. As usual, we will be reserving the last 10 to 15 minutes for audience Q&A. So if questions come up, please do pop them into the Q&A portion using our Zoom controls. With that, I will hand the virtual mic over to our speakers.
All right, let's get started. So learning objectives for today, we're going to talk about 3 main recommendations for discussing nutrition and physical activity with families who might be struggling with a young person with eating disorders. We should be able to name about 3 facts about eating disorder prevalence, particularly among different socio-demographic groups, and talk about different evidence-based strategies to support patients and their families, particularly if they don't have access to specialized eating disorder care in their communities. Next slide, please. So something really critical just to kind of start to frame this discussion is that eating disorders lead to severe medical consequences, including death. Next slide, please. So just to highlight a little bit about anorexia nervosa in particular, we know they have really high elevated lifetime mortality rates, somewhere on the order of actually like 6 to 8%, which is actually like kind of on par with ALL, like a really common childhood leukemia. So that always helps me, kind of centers me when I'm seeing these kids, just how serious these disorders are. We know that this mortality rate is more than double that of schizophrenia, almost triple that of something like bipolar or major depressive disorder. And it's really because of this union, right, of both medical complications and psychiatric complications, both posing different risks. So about 1/3 of patients with AN who do pass away, they pass from cardiac complications of the illness, from malnutrition, and we lose about another 1/5 to suicide. So you can see how it's really critical that we are attending to both the medical complexity as well as the behavioral health complexity of this patient population. Next slide, please. So if I'm in the primary care setting or I've got my medical provider hat on, I have to remember that the psychological piece of the eating disorder is heavily influenced by malnutrition itself, right? So something we often hear from patients and families or from their doctors is like, well, sure, they can gain weight, but that's not helping them. That's not helping them feel better. But in reality, what we find is that as a primary care provider, if you're able to help re-nourish and put weight back on, actually, that's really going to help the psychological piece of the illness too. So you'll hear about that kind of throughout today's webinar. Next slide, please. Of course, there are lots of diagnoses in the eating disorder space. This isn't even all of them, although this certainly encompasses the more common ones. I think something really important to emphasize here is that in the primary care setting, you don't need to make a diagnosis, right? Our job is just to identify concerning behaviors, red flags, medical complications, and then to kind of set the stage for recovery, whether that's connecting with further treatment or enacting some of the medical care, right? But we don't need to worry so much about these diagnostic categories. Again, we're tasked with kind of finding those red flags and intervening early in the course of illness. Next slide, please. So again, we're identifying concerning growth patterns, concerning behaviors. We're starting that process of initial medical management, including how to involve families in treatment, and then facilitating any referrals that might be available to the family. So, kind of a glaring gap in our world in child and adolescent eating disorders, we actually don't have a really great, easy, validated screener to pick up eating disorders. And so Dr. Bruett may offer different advice here, but I always say just be a human with your patients, right? Like if there's smoke, there's probably fire. Ask the questions that make sense, that come to you intuitively as a provider, right? Like tell me about your eating, just really open-ended. How important is it to you, what you're eating? Are you thinking about food all the time? Like how much of your day are you kind of like, is this rolling around in your head? Are you on a diet? What made you decide to start dieting? Have you lost weight recently? What was the goal of that weight loss? I'm just curious. How do you feel about your body? How do you feel about your weight, right? Just these really open-ended questions that can kind of open the floodgates of what might be going on for a young person who's struggling with an eating disorder. That is still my approach to this day. Next slide, please. So, you all are experts in looking at growth curves, but we'll just go over a few anyway. So we know that normal growth takes many shapes, right? You can go ahead and click and see some different patterns here. Yeah, so this is normal, right? It's a higher percentile BMI, but the young person is tracking appropriately on growth curves. Yep, keep going. Yeah, similarly, someone tracking at that 10th percentile for BMI, it's totally fine, right? As long as it's their trajectory. No concerns with any of these growth patterns. Keep clicking, please. Yeah, and some deviation is normal, right? Particularly around puberty, we tend to see some spikes or dips, and that's okay. We're just looking at that overall trend, again, to see if we can capture any kind of red flags or reasons that we should be kind of exploring further the idea of an eating disorder. Next slide, please. So where we get concerned is falling off this BMI curve. So, right, someone growing nice and beautifully at that 50th percentile who suddenly is tanking and crossing multiple percentiles. We want to keep our medical hats on, right? Thinking about other things, medical causes of weight loss, but certainly this should be a red flag to screen for eating disorder behaviors as well. Yeah, similarly, someone who's low weight and totally falls off the growth curve, I'm just as concerned about this person. And we would call these cases anorexia nervosa, right? Obviously, we'd want to get some history too, but typically in the setting of eating disorder behaviors, these kids would be diagnosed with anorexia nervosa. Click again, please. So here's a little bit different, right? Same trajectory, but this is a young person who is growing at the 85th percentile and loses the same amount of weight. But if you just looked at that last weight data point in isolation or BMI data point, you might say, oh, that's normal, right? 50th percentile. But actually what we know is there's something about that degree of weight loss, right? That where they started to where they are now, that's the thing that makes kids medically and psychologically ill. So in fact, Even someone with this quote unquote normal BMI is going to be just as medically and psychologically compromised as the other two patients we saw kind of falling off the growth curve to a lower growth percentile. Click again, please. Just so you know, we call this in the field atypical anorexia nervosa, but really for all intents and purposes, this is just anorexia nervosa. It looks exactly the same, both medically and psychologically. Next slide, please. Go ahead and click. So a flat BMI curve, also concerning, right? Because if someone's gaining height, this means that they're losing weight. You can click a few more times. Yeah. So these are all red flags to be looking also for something like an eating disorder. Next slide, please. So weight loss indicating malnutrition. You don't need to memorize this. It's just kind of a quick and dirty reference point that helps me triage in terms of medical acuity. I'm looking at that last row there. This is how we classify malnutrition. So for someone who comes in to see you who's lost greater than 20% of their initial body mass, I'm really worried medically about that kid. I know that they're going to have a higher chance of having medical complications that will land them in the inpatient medical hospital. So just, again, a kind of quick and dirty reference point as you're triaging cases in the office. Next slide, please. So this is this concept of weight suppression. You don't need to memorize formulas or anything like that, but just as an example, let's say you have two girls, both have lost weight due to an eating disorder, same age, same height. They've both lost significant weight through the same kind of mechanisms, right? Restriction, purging, diet pills, what have you. So Jill starts at 125. She loses weight to 85 pounds. So now she has a BMI 14, which is low, right? That represents a 40-pound weight loss. Jane, on the other hand, starts at 260. She loses to 128, such that she still has a quote unquote normal BMI, right? But that weight loss represents a 132-pound loss. A question we often get is like, are these kids equally malnourished? Are we equally as worried? Go ahead and click. Next slide. So again, this idea of weight suppression, you don't need to know the formula, but the idea here is that even though Jane is at kind of this quote unquote normal BMI now, she's lost over 50% of her initial body weight, right? Compared to Jill. Both could be very ill, but I'm actually more worried about Jane in this scenario because again, it's not that last data point being normal, it's how far you fell, what the change in trajectory that actually predicts how kind of medically compromised you might be. Go ahead and click. So again, this degree of weight suppression actually predicts how medically compromised you are, not just that initial weight. So we know that the farther you fall off your curve, you have slower heart rate, so more bradycardia, more persistent loss of menses, lower T3 is just kind of a soft metabolic marker. And in fact, these young people actually tend to have worsened ED, eating disorder psychopathology. So sometimes more kind of entrenched eating disorder thoughts and behaviors, as well as increased like suicidality, things like that. So we must pay attention to these kids who maybe aren't classically low weight, but are at increased medical and psychological risk. Next slide, please. Yeah, so rapid weight gain can also be a concern for an eating disorder, right? Go ahead and click. Again, we want to, be thinking about other medical causes, but could this also represent binge eating disorder, right? Which is actually our most common eating disorder diagnosis. Absolutely. Next slide, please. And actually, normal growth doesn't rule out an eating disorder, right? So we're not just going by the growth charts, but this could be ARFID, avoidant restrictive food intake disorder. This could be bulimia nervosa. We don't know. So again, if there's smoke, if there's a red flag, just following up and making sure that you're tracking, so you're not missing one of these young people just based off a normal growth curve. Next slide, please. So let's get into kind of quick and dirty medical evaluation. So of course we want a height and a weight. in a gown. So we're getting a really accurate BMI and weight. We do vital signs. We want orthostatics too. In malnutrition, we know there's increased risk of syncope, orthostatic changes from lying to standing. Of course, a history, a physical exam, careful review of growth charts, as we just went over. If we've never seen a patient before, or if there's, significant medical compromise, I want an electrocardiogram to see degree of bradycardia. Is there any degree of AV block, any kind of arrhythmia I need to be acutely worried about? We'll draw serum labs. We'll talk about that in the next slide. And then, of course, facilitating referrals and follow-up to specialists. Next slide, please. So a little more specifically, we talked about the ECG. Let's talk about initial labs. We see a lot of abnormalities on lab panels, but not always, right? And so we want to be careful not to undermine kind of how sick someone is if their labs come back normal. We don't want to invalidate the struggle. Things we'll see on CBC, leukopenia is by far and away the most common thing we see in the setting of malnutrition. CMP, we're looking for liver enzyme elevations from malnutrition, and of course, electrolytes, worried about that, mag and phos, potassium, sodium, these are things that land our young people in the hospital. We get a lipid panel, which is kind of interesting. I'm not worried about high cholesterol in these patients, but in the setting of starvation, our body, liver in particular, starts to release cholesterol and triglyceride stores. And so we actually see elevated lipids in patients with malnutrition. So really important to explain that to families so they don't walk away thinking, well, they're saying I'm malnourished, but I have high cholesterol. Do I need to be on a diet, right? Just don't want to reinforce something that's not true. We get inflammatory markers to make sure we're not missing anything that could be underlying weight loss, right? So like thinking about like Crohn's or IBD, TTG, IgA, looking for celiac disease. Vitamin D and zinc are often low in our patients, a really easy thing to replete on an outpatient basis, and then looking at thyroid studies as well. On a urine sample, we're looking at specific gravity for both dehydration, and then sometimes our patients have eating disorders that before they come check in with us, the eating disorder wants them to drink a lot of water to kind of artificially elevate the weight, right? As to not raise alarm bells. So really critical to look at that specific gravity. pH can be an indication of purging or laxative use. It's not perfect, but the more alkaline that pH is, the more elevated the pH is, the more concerned I am. I'm at least going to ask the questions. You might consider a urine tox screen, and then of course, beta HCG as well. DEXA is indicated when there's been amenorrhea, secondary amenorrhea from malnutrition for greater than 6 months. So looking at the integrity of the bones, which is something we see with more long-standing malnutrition. We start to see stress fractures and frank fractures. Next slide, please. So primary care treatment, food is the best medicine in this case, and it's okay to say that to patients and families. You're going to mobilize caregiver involvement as much as you can. Dr. Bruett will talk more about that. Of course, medically stabilize abnormal vital signs and electrolytes. You're going to monitor growth and development over time and really establish clear roles. Once there's a team, with hopefully a nutritionist and a therapist, maybe a psychiatrist, make sure everyone kind of knows what they're doing, but is also working collaboratively together to not undermine any of the team members. So treatment goal weight, this can be a little bit hairy and to be honest is not a perfect science, but just briefly, it's like, where do we want this young person to recover to based on where they were historically growing? So typically we say, look at that BMI curve and where they were growing from like age 4 on is probably where they need to end up for both medical recovery and psychological recovery. Again, there's often a lot of variation in growth history, so it's a little can be difficult to say if you've got one of those like really messy kind of growth charts, but do your best. And if someone is well above the growth curve, like 99th percentile or greater for BMI, and they're losing weight, really at that point, the minimum goal is no further weight loss. Some of those kids actually do need to gain weight for psychological recovery, and actually some don't. And again, it's not a perfect science. So you kind of let psychological recovery as well as like, right, menstrual status, vital signs, all of those things help guide for some of those curves where it's just not quite as clear where the young person needs to restore weight to. Next slide, please. And go ahead and click one more time. Yeah, so for someone with, again, what we're calling atypical anorexia, really, I'm just going to call that anorexia for the purposes of the talk. You know, if Dr. Bruett and I were collaborating on a case, I was seeing them medically, she was the therapist, you know, we would share with the family that they really should, the plan is to restore weight back to that orange star where they were historically growing on the 85th percentile, because that's the best evidence we have for long-term medical and psychological recovery. Next slide, please. So treatment cadence. This is difficult because I know you're really busy and you see a bunch of patients. But in a dream world, this is kind of what we aim for. If the young person is underweight, so they're malnourished, you know, we like to do frequent follow-up visits, even if it's just like a quick weight check and vital sign check, until they're, you know, really making substantial progress or they've really established with another team who's going to track the weight in parallel with you. Ideally, that's every 2 weeks. Again, I know that may or may not be realistic for your practice. You can space out visits. Once again, they're gaining weight steadily. They're kind of in that target goal weight range. Their vital signs have normalized. Totally okay to go ahead and space out those visits. And, you know, I say this with humility as someone who sometimes is like, as a medical provider, like, I don't feel like I'm actually doing anything for this family, but it's important to remember that it is just an empowering touch point, right? For the family to meet with you, to remind them how important this process is, how they must continue to restore weight, even when it's getting difficult. So it just really reinforces kind of the seriousness of the illness and keeping them motivated to continue on the path towards recovery. Next slide, please. So some kind of loose goals that we tend to follow, you really want to aim for like 1 to 2 pounds of weight gain per week. That's considered a very kind of successful cadence of recovery. Sometimes in our program, we're pushing young people to gain 3 to 4 pounds a week. That's not unusual. And so anything within that range is you know, successful and they're on the right track. It's not unusual for young people to require between 25 to 5,000 calories a day to achieve that goal. If they're severely underweight, if they're really hypometabolic, you know, it is not uncommon that we discharge kids from the hospital at 5,000 and above kilocalories per day. So don't be, you know, surprised if you're seeing numbers like that. They really might need that much energy to start the recovery process. If you don't collaborate with a nutritionist, that's okay. We really say 3 meals a day and 3 snacks is sufficient. That's what you need to recover. And we trust that families, you know, kind of know what that means intuitively in terms of what they need to feed their child to start the renourishment process. And really, we say caregivers are 100% in charge of meals, especially at the beginning of recovery and treatment. That can feel really odd for those of us who are used to caring for adolescents and trying to like really empower them towards independence, right? This is a reversal that can be really challenging for families. And we know when there's an eating disorder that's kind of hijacked that brain and they're really struggling, young people have a hard time making good decisions separate from that eating disorder voice. And so this is where we're really roping in parents to help renourish the young person, again, especially at the beginning of treatment. Next slide, please. So again, we're empowering and encouraging caregivers to really like tap those foods that are normal for their family and for their culture. You know, as we said, if someone is going to be having 4,000 to 5,000 calories for recovery, families don't need to eat identical portions, right? They're going to have different kind of energy requirements throughout the recovery process. We want patients to return to eating all the foods they ate prior to the onset of disordered eating. We see a lot of folks who come in, you know, newly vegetarian, newly vegan, newly whatever, right? And it's very clear that that change was part of an eating disorder as opposed to something that would be kind of culturally normal for their family. And so we really push to get folks back to what they were eating before the onset of the eating disorder. We don't want to go down the road of diet foods, again, a very slippery slope that kind of lets that eating disorder live and thrive. And we want meals and snacks, you know, not only provided by caregivers, but also supervised by a trusted adult. So where there can't be a caregiver, sometimes we're tapping aunts or grandparents or, you know, school staff if they're back at school, just to make sure, again, that we're really doing everything we can to renourish the young person. Next slide, please. So I won't belabor this, but unfortunately, there really aren't good data for the use of medications like SSRIs, particularly for anorexia. So yeah, it is disappointing that we don't have a stronger evidence base in this domain, but typically we're not starting SSRIs on these patients with eating disorders. We don't find that they're incredibly helpful for any of the kind of core psychopathology of the eating disorder. Next slide, please. So hospitalization criteria, this is published on our website, so you should be able to find this pretty easily if you need it. The big ones, bradycardia, so heart rate less than 50 during the daytime, hypotension, any blood pressures less than 90/45, hypothermia, orthostasis, and even just being severely low weight sometimes can we'll bring folks in if they're just continuing to lose weight and not able to make any progress in the outpatient setting. If you call us, know that we are busier than we'd like to be and often are in a full bed situation. So you should call us, you should get advice. We will help kind of triage if your patient is meeting one of these metrics, but maybe we don't have any beds available. Know that we are working hard to kind of triage cases and think comprehensively about who kind of needs the bed the most. So again, it's not like slam dunk if they have one of these that they'll 100% come in, but do call us so we can help think collaboratively about the case for inpatient hospitalization. Next slide, please. So some, if the more unusual reasons for admission, but still warrant admission, right? Electrolyte abnormalities, prolonged food refusal. So you're really worried about just hypoglycemia. Sometimes when there's really like intractable purging, we see esophageal tears and hematemesis. So all of those things, again, please send to the ED or give us a call to talk through the case. Next slide. So again, I want to acknowledge that walking the tightrope in primary care is so difficult, right? Because we're, also dealing with folks who are struggling with higher weight, and how do we deal with that problem while also not kind of precipitating or putting folks at risk for eating disorders? And I'm not sure that the field has totally figured this out yet, but I just want to acknowledge that it's hard, right? We know that adolescents who diet are at higher risk for developing eating disorders, and weight loss itself can be a precipitant or a risk factor for developing an eating disorder. So really, we want to focus on healthy and balanced behaviors, move away from weight goals. We know that that decreases risk of kind of flipping someone into an eating disorder headspace. And instead of restriction or, focusing on the minutia of calorie counting, we want to focus on regular eating, and all foods in moderation, a more kind of moderate approach. Next slide, please. Eating meals together as a family, right, to encourage social connection, not in front of a screen, can be powerful. We want to encourage physical activity, of course, as primary care providers, but, focusing on things like purposeful, joyful movement, not exercising because you're trying to kind of achieve a certain aesthetic, right? We want to positively reinforce positive behavioral changes versus weight loss itself, because really, there are critical ramifications of weight stigma in medicine that continue to really perpetuate and precipitate eating disorders. So we have a lot of power in the space. We have to be careful with that. Next slide. So just some if-then scenarios really quickly. If there's acute weight loss, like so more than 5 pounds in a month when you're following a kid, please get electrolytes and make sure they're stable. Caregivers are feeling really disempowered. They're not able to really help renourish the kid. That might be a time to consider a higher level of care from an outpatient setting. Maybe they're gaining weight really quickly, like greater than 5 pounds in a week. You might also want to get electrolytes, right? We see kind of profound fluid shifts when we go from a malnourished state to eating again. And so, again, you just want to make sure that we're establishing medical stability. Abdominal pain constipation is the rule, not the exception. So things like Miralax Colase, totally safe and can be really helpful in getting folks through the renourishment process. There's intense body dysmorphia interfering, right? We have parents remove scales from the house, throw them away, cover mirrors, right? These are just little things we can do as primary care providers to help this process along. Okay, I'll turn it over to Dr. Bruett.
Thanks so much, Dr. Downey. So shifting gears a little bit and building on what Dr. Downey has shared. So really want to highlight how eating disorders don't discriminate, unfortunately. And I'll talk more about that. Next slide, please. Just a little bit about prevalence rates. Eating disorder prevalence rates have increased. We believe this is probably due to a couple of things, including enhanced screening and better detection of eating disorders. And as Dr. Downey mentioned, the most common eating disorders are actually those that sort of fall into this like not otherwise specified or other specified bucket, and also binge eating disorder, anorexia nervosa and atypical anorexia are actually the least prevalent, even though those are the folks that tend to come see us in clinic the most often. Next slide, please. Okay, so I hope you take just one or two things from this slide. You don't need to remember the details here, but what I really hope you take away is the idea that when we look at our epidemiological studies of folks with eating disorders across racial and ethnic groups, there really aren't that many group differences. Some studies we see small trend level differences, but my guess is if we had larger epidemiological studies, those differences would kind of come out in the wash. So we want to really think about, there's been this unfortunate myth in the eating disorder field that they mostly impact thin, white, upper middle class women, and that has caused folks who don't fall into those stereotypes to not get detected and not get referred for proper care. And we really do see eating disorders across groups. We do know that when, for example, there was a study done where physicians were shown two vignettes of kind of identical eating disorder presentation, and when one person was white and the other person was non-white, the physicians tended to recommend that the person who identified as white be referred for, raise concern about eating disorder, be referred for appropriate care, whereas they were less likely to do that for the person who identified as non-white. So we want to really keep this in mind when we're meeting with our patients. Next slide, please. Similarly, socioeconomic status is not associated with eating disorders. They really occur at similar rates across various socioeconomic groups. However, food insecurity is associated with increased eating disorders. And this kind of makes sense when we think about what Dr. Downey said about how dieting is one of the most powerful predictors of eating disorder that we have. And we know that food insecurity, while people may not be purposely dieting, they may have periods where there's less food available. They may have dietary restriction kind of inadvertently, and that can precipitate eating disorder. We also see when we look at folks who identify in minoritized groups in terms of their sexuality or gender identity, when we compare those to cisgender heterosexual populations, they do have higher rates of eating disorder. And this is likely for two reasons. We think primarily it's because of the unfortunate stress and stigma that folks who are in minoritized groups experience, and how that can just raise risk for mental health concerns in general, and eating disorders are no exception. And then the other is that sometimes certain eating disorder behaviors can serve to kind of like affirm aspects of somebody's sexual or gender identity, for example, looking a particular way. Next slide, please. So thinking about early signs. So if you're hearing about any of these things in your visits, we want to really have you dig in a bit more and ask more questions. A couple of things that I want to highlight on the right-hand side here. Dr. Downey mentioned we'll often see folks becoming vegetarian or vegan. We know that many folks become vegetarian and vegan, and that is not always a cause for concern with eating disorder. However, when we see it kind of temporally at a similar time to the development of the eating disorder, we get really worried about that. And we want to kind of advise families to not permit that dietary change right now while the eating disorder is underway. And they can always come back to it later once this child is in recovery. But sometimes it can be a way for kind of a culturally sanctioned way for folks to engage in restriction, for the eating disorder to engage in restriction. We've also seen cases where becoming vegetarian or vegan means that folks are eating fewer calories, sometimes inadvertently, like if their family is not vegetarian, so they're only having the sides at dinner while their family's having more food than that, that can sometimes precipitate weight loss, which can then precipitate the onset of the eating disorder. So we see it going both ways. And then the second one is this last point here, that sometimes we see folks when they become malnourished becoming really interested in food, but still not eating food. So we might hear families say, oh, she's been watching tons of cooking shows, or he's been like making all these elaborate desserts for the family, but not eating them. And sometimes families understandably think that's a good sign, but that's actually cause for concern for us. And we will advise like no baking unless you're eating what you're baking for this period of time. Next slide, please. Okay, Dr. Downey talked about areas that we would want to assess. I want to note this point in the lower right-hand corner here is that we often think of eating disorders as highly related to body image concerns, and they can be. However, they're not always. And that I think can be for two reasons. One is that some people really don't have body image concerns in the context of their eating disorder. And when they do, that can be focused on thinness or muscularity or other sort of like aesthetic ideals. The other is that the eating disorders can be prone to kind of wanting to remain in secrecy, wanting to kind of not raise alarm bells for folks so they can kind of proceed as they're going. And so young people might have difficulty kind of disclosing the fears that they have around body image. So if you have somebody in your office who you're concerned about for eating disorder and they're not endorsing body image concerns, don't let that kind of like lead you off track. There probably is still an eating disorder if you're concerned about it. Next slide, please. You all work with young people, so you're very familiar with the idea that we often get different stories from different people, right? When we're working with folks, and that's normal, and is even more pronounced in the context of the eating disorder, largely because of this way in which the eating disorder can sometimes try to protect itself, and not kind of give up what's going on. And so these are some examples of things that Dr. Downey and I might see in our clinic in terms of differences in what patients versus caregivers might report. And so we do want to really, when caregivers are able to participate, even if it means like giving them a call during a visit or finding some way to get that collateral information, we do want to get caregivers' perspective on what's happening, because otherwise we might be inadvertently missing things. Next slide, please. Okay, so Dr. Downey talked about how weight is just one treatment goal that we have for folks, and yet it is a really important one, because when folks are malnourished, they're really typically not able to break out of the psychological symptoms that exist in eating disorder. They really need that nutrition to be able to think clearly about things like food, physical activity, body image, things like that. Next slide, please. Okay, so as Dr. Downey said, you don't have to in primary care worry about making a specific diagnosis, like determining if this young person in your office has anorexia or bulimia. Similarly, in thinking about treatment goals, the nice thing is that all of our evidence-based treatments for adolescent eating disorders have similar targets and kind of ways of approaching those targets. So we also don't have to worry too much about like, well, what if it's bulimia, or anorexia? Like if I do this thing, is it going to be wrong? No, they really share these common goals. So focusing primarily or first rather on weight restoration or stabilization, relatedly normalizing eating patterns to doing those 3 meals a day and 3 snacks, as Dr. Downey said. In the case of binge eating, that normalization of eating patterns is our biggest way to reduce binge eating. Binge eating is almost always a response to some sort of dietary restriction or restraint. So we really want to focus on helping people eat regularly. We want to try to protect against compensatory behaviors. So these would be things like purposeful vomiting, exercise to try to make up for eating, things like that. In the case of vomiting, we would want to advise families to be monitoring after meals and snacks. And we want to kind of ask them, like, when does purging tend to happen? Often that's within 30 to 60 minutes after the food intake. And so we would encourage families to keep young people in kind of like the common area of the home for about 30 to 60 minutes after meals. And we frame that as like we're trying to protect them from the eating. Later in treatment, we're working on reducing weight and shape concerns and body acceptance, things like that, but we're really not able to do that until folks are nourished. We wish Dr. Downey and I would like pay a lot of money to be able to have a tool to talk people out of the eating disorder, right? And sort of help them like understand and get it and move through this, but it really does hinge on nutrition. We really have to focus on nutrition before folks can really have that cognitive flexibility to think differently about the eating disorder symptoms that they're experiencing. Next slide, please. You don't need to remember this, but these are the treatments that have evidence to support them, or some of these are the treatments that have evidence to support them. So family-based treatment, or FBT, and cognitive behavioral therapy all have some solid research to support their use for young people with eating disorders. DBT is also a reasonable treatment for folks, particularly with significant kind of like comorbid behavioral targets, like if there's significant substance use or really significant suicidality or self-harm, we might refer to DBT, even though it's not been studied as much in adolescents with eating disorders. And then, we're grateful that higher levels of care like IOP, PHP, residential exist, because sometimes families do need that extra level of structure and support. And that could be because caregivers are really not able to be available to do supervision most of the time, or it might be that they've been doing that. And for whatever reason, the eating disorder is so strong that they really need kind of more structure and support to be able to move forward. However, as you all know, there's not a lot of research on outcomes in those types of programs. They're really hard to study. So we're typically recommending outpatient care as a first line of treatment when it's available in the local community. Obviously, also geography can influence these decisions too, although we have quite a bit of virtual options these days post-pandemic, which is really nice. And then across the board, having some sort of family involvement is best supported. So even if a young person is in a day treatment program, I want to see their parent, either caregiver, being involved and kind of at the very least understanding what the treatment plan is and how they can support the young person when they get home, if not being even more involved than that. And the reason for that, well, it's multiple fold. You're probably well versed in including families in many of the treatments that you provide, and particularly in the case of eating disorder, because the eating disorder makes it difficult for the young person to make good decisions about things related to their eating disorder. They really need other folks to step in and support. Next slide, please. Okay, so some sort of troubleshooting here on things that often come up. Usually the adolescent will not be interested in treatment. When they are, it's great and we can involve them. But if they're not, it's okay. And that's why we want to bring in caregivers. If the family is unable to participate, maybe you have somebody who doesn't live with their family or came to this country alone. We want to use motivational interviewing skills to try to both guide them toward recovery. So thinking about increasing nutrition, things like that. And if treatment is available, to help guide them toward being willing to engage in care. And this might take place over a long period of time. So Dr. Downey spoke about ideally you're having kind of fairly frequent visits with patients that you're worried about for eating disorder. And we would recommend kind of using these strategies a little bit in each visit. We're not expecting that you do kind of one session of MI in one of your visits and that somebody's really ready to engage, and that's okay. Next slide, please. Okay, so the family is available to support and the young person, either there's not going to be specialty care available or there's long waits, which is common, unfortunately. We're going to provide psychoeducation. There are packets on our CalMap website, and we have a QR code at the end of this slide. So we recommend if you want to just printing it out or giving the family the link. That has lots of good information. We'll talk about illness externalization. And then Dr. Downey talked about really increasing regular eating, and then thinking about the role of reinforcement. So particularly in the case where, maybe folks are having difficulty eating a wide variety of food, or they've cut out chips, as Dr. Downey mentioned, want to think about really like reinforcing the effort that young people are making. I'm really impressed with you for having that food that was difficult for you. Next slide, please. Okay, so externalizing the illness. So you've heard Dr. Downey say things like the eating disorder can sometimes cause young people to drink a lot of water before their medical visit. We purposely say it that way. We don't say Sally drank a lot of water before her medical visit. Sally was like, not following the rules and drank this water. We really think of the healthy young person and the eating disorder as separate. You might do this in other things like obsessive compulsive disorder or certain medical illnesses where you're kind of externalizing the illness. And we find that this is a really good tool to help. Eating disorders can be so frustrating for everybody, including families, probably primarily families. And this can be a really helpful tool to help families kind of remember, like, okay, this is not like my healthy Sally that's engaging in these behaviors. It's the eating disorder that has kind of co-opted her right now and is causing her to do things that she would never do outside of the context of the eating disorder. Next slide, please. Next slide, thanks. Okay. Oftentimes families have I would say almost across the board, right? Families have good instincts about taking care of their kids. When we're talking about teens, they've usually fed them their whole lives and kept them healthy. That hasn't been an issue. And so they have good instincts about what their child needs, and the eating disorder often has caused them to get off balance. So think about like a family I consulted with where the mom, we had a call and she was worried about her daughter, and she said like, she says she doesn't want to eat meat now. She says she wants to be a vegetarian. And so I'm cooking all these special meals, and kind of me sharing with her that we actually think that her daughter should be eating all the foods that the family eats and not cooking special meals. This mom was so relieved, like, okay, it's sort of what I thought, but like, I just didn't know. And this can obviously be amplified in families that, maybe, experience oppression in other ways where they have maybe acculturation differences between young people and parents and things like that. And so we want to really support families that they should feed their kid the way that they know that they need to. And they may need advice from us to increase the nutrition and focus on denser foods. And we talked about these last things. Next slide, please. Okay. There can be some misconceptions about caregiver-led nutritional rehabilitation, which is kind of a core component of family-based treatment or FBT. I really think of it as hinging on love. So really this idea that caregivers love their kids too much to let the eating disorder overtake their life and cause them to become sicker. And so they really, their child is lucky enough that they have somebody to step in and support them to make good decisions about nutrition and exercise in the short term. And then we'll support them to move back to age appropriate responsibility as time goes on. So really advising families to kind of balance warmth toward their child and firmness against the eating disorder. Next slide, please. Okay. Thinking about how you can support patients directly, can provide general coping. So I'll often ask, it sounds like things have been really hard. What are the most difficult times? Is it before, during, or after meals or some other time? And then you might brainstorm with them. So, okay, in the next 2 weeks until I see you again, can you try to use some coping after the meal, since that's the most difficult time? And you want to really coach them to focus on really active coping. So maybe like talking with a friend, watching a really funny TV show, playing a game with the family, not more to sort of like inner focused coping, because the eating disorder thoughts will be too loud. We talked about motivational interviewing and then the role of reinforcement and really working on reinforcing behavior. Next slide, please. Okay. We talked about these things. Next slide, please. So we in our clinics screen all families for low resource or for food insecurity. We use the 2 questions on the left that have been well validated. We provide, particularly in the Medi-Cal clinic that I run, we provide a list of food bank resources to all families who come into our clinics. You could consider doing that if you don't already. And then most insurances, if you as a medical provider prescribe a nutritional supplement like Booster Insure, most insurances will cover it. So that can be a really nice way for families to get some free nutrition, especially for those that are low resource. We don't always recommend using these supplements. That's sort of a family decision, but it is a nice way to get some free calories. And there's nothing wrong with using them. Next slide, please. Okay, so often Dr. Downey will make recommendations that folks need to rest, particularly if there's vital sign instability. And sometimes I'll make the recommendation that the young person needs to rest if the exercise is sort of part and parcel of the eating disorder. Then we really need the young person to take a break from that so their body can have the experience that they can not exercise and still be okay. When they're returning to exercise, we want to have them go low and slow. So starting with like a walk around the block with mom or dad after dinner. We really want to encourage like returning to social physical activity, joyful physical activity. I'd much rather have somebody start going to a few soccer practices a week than going to the gym and running on the treadmill. Next slide, please. Some tips. Eating disorders can sometimes hear things in a way that we don't intend. So we want to avoid comments. I basically at this point don't really comment on people's bodies or appearance. It's just really risky. And so think about other things that you can kind of make small talk with. And then finally, adolescents who are in eating disorder treatment, it's very difficult for their eating disorder to make these changes, and that may cause them to not like their therapist very much. As long as the family is trusting of the therapist, that's a good thing. And it's not abnormal for kids to not really be a big fan of their eating disorder therapist, especially at the beginning of treatment. Next slide, please. Okay, so I'll leave you with these. The slides will be posted, and these are some tips for if hospitalization is needed, how you can talk about that with your patients. Next slide, please. And finally, this is the link to our online resources. So tons of resources there for both families and PCPs. And I will stop there. Thank you all.
Wonderful. Thank you so much for that talk. One question came in, and this will be to Dr. Downey. You mentioned getting basic metabolic panels. Is that sufficient, or is a complete metabolic panel better to get things like calcium, albumin, alkaline phosphatase?
Oh, yeah. Great question. So we typically start with a CMP as kind of a baseline metric. So I'm doing a new evaluation. I don't have recent labs on someone, or at least not since their period of malnutrition. Then I like to get the CMP to get a baseline of, as you mentioned, all of the things. But as I'm tracking over time, like let's say there's been more acute weight loss or a lot of weight gain, unexpected weight gain, then I'm just doing a BMP really to look for electrolytes and medical stability. There's other things on the CMP that we might track. So, for example, LFTs or some of those things that take longer to correct and they're not so acute. I might repeat that like every 6 months as treatment continues, but really baseline CMP and then totally fine to pivot to BMPs, Mag and Phos, as you're thinking about treatment more acutely. It's a great question.
Wonderful. Another question. I have many patients who tell me they skip lunch because they don't like the food at school. Yet at the same time, many of these families are experiencing food insecurity, so school often accounts for a large part of their nutrition. How would you recommend counseling this type of patient if they have an eating disorder?
Yeah, we definitely hear that a lot as well. And sometimes it can be sort of like a trend in schools for folks not to really eat much at lunch. In this case, particularly if that food is really needed, we would sometimes enlist the help of the school for lunch supervision. So we'll do this anyway, even if kids are bringing lunch to school. But if the eating disorder is making it difficult for them to eat at school, or we suspect that it may be, we would empower the family, or sometimes do it on their behalf if they prefer, to see if there's somebody at school who can supervise lunch. So that might be like a wellness counselor or a school nurse. Schools are not required to provide this, but I'd say like 75% of the schools we work with are willing to do it and can work it out. Because it sounds like it's just really too difficult for this young person to do that on their own right now.
There's no thoughts there. I'm going to go ahead and ask our staff to put up our QR code. And if you, as our audience, would go ahead and answer a few of our poll questions for us. Marcus, let's go ahead and put up the QR code and drop the link into the chat. This is how you can get CME credit. This is how our system knows that you're here and that you deserve credit for today. So this is also very important. One of the comments that came up has to do with the importance of geography in terms of like what resources are available to you. We know that these resources, the specialty resources, are not evenly distributed. So if you could just comment on what telehealth resources you know about, or even what geographic spread is served by UCSF's program that you work in.
Downey, do you want to talk about UCSF's program?
Yeah, sure. Yeah, so we primarily do see folks, at least in the outpatient setting, from, I would say, like a 2-hour radius. We share many patients with Stanford, who geographically is not that far away, also has an excellent eating disorders program. In terms of inpatient hospitalization, things get a little bit more difficult. If you ever have a case that you want to talk through to see if they meet medical inpatient criteria, anyone can call us from anywhere in the state. It is not infrequent that we are hospitalizing patients from Southern California because there aren't beds at UCSD or UCLA or other reasons. They're connected with our program in some way. But I know any of the major children's hospitals who have inpatient eating disorder programs would be happy to chat with you about those cases. But certainly anyone in the state is welcome to call our inpatient service for advice or or to run a case past us. Yeah, Lindsey, maybe I'll turn it over to you.
Yeah. And in terms of mental health services, I'd say we have some flexibility. We try to primarily serve patients in the Bay Area, and we wind up serving patients elsewhere in the state. We are only able to work with folks in state in California. There are some nice online resources that have developed in the pandemic, since the pandemic. So two one is Within Health and one is Equip. And they provide virtual care for eating disorders throughout California. So those are nice resources as well.
Wonderful. Thank you for sharing those resources. Another question came in. This person's wondering, when is the timing for patients to graduate from family therapy? She has an autism patient who's been in family therapy for ARFID for 2 years now, and now still has daily, frequent, mild thoughts about how she appears to others when she eats foods. Doesn't impact the amount of intake. Weight's restored. She does a good job cooking with her parents. So yeah, therapy needs for this person, or treatment considerations.
Yeah, it's a great question. It can be hard to know when to discharge patients from therapy. I'd say in this case, if we're thinking of maybe your role as like the medical provider, the psychiatrist, I'd probably be reaching out to the therapist to ask her what the treatment goals are and what the therapist is looking for discharge. Where I sit, I'm mostly focused on behavior. So if kids are eating well and they're eating what their family eats or what they ate prior to the eating disorder, even if there's still some remaining body image concerns that aren't getting in the way of eating, I'm okay with that. I would say it would be different if the young person's really distressed by those body image concerns and they're saying they want help with that. And that might be a reason to think about whether like some individual support, like particularly focus on body image, would be helpful. But if those thoughts aren't distressing, I'd say I wouldn't worry too much about that. It's unfortunately a fairly culturally normative experience that people have. I don't know if you want to add anything, Dr. Downey.
Okay, wonderful. Thank you for those thoughts. And I guess there could be a range of opinions here. Well, thank you so much for coming to today's webinar on eating disorders in primary care. Our next webinar will be on May 29th, and this is actually on tips for integrating behavioral health into your primary care practice, some of the workflow considerations, staffing considerations, sustainability, a lot of the kind of the nuts and bolts of how you actually make this work in the context of day-to-day primary care. So hope to see you then. A big thanks to our speakers, Drs. Bruett and Downey, for speaking with us today. And thank you to all of you for taking time out of your lunch to join us today. Take care.